think it should be an E.
E, yes.
Right?
Correct. Yes, correct.
Maybe you can go to your Zoom and just see if you've, I'm not sure. I mean, whoever's
How do I do that?
yeah, the account on your behalf, they might have typed in your name as VIVIAN.
Yeah.
Rather than E.
Because probably not controlled by me.
Yeah, certainly not. I don't imagine you to type your own name wrong.
That's normal.
Everyone.
Hello,
Hi,
sir. Good
Dr.
afternoon.
Faria, how are you?
Yeah, fine. Thank
Hi,
you.
Dr. Lim, Dr. R.
Hello. Hello.
Welcome.
Hi.
Welcome to India virtually.
Thank you.
One day
Thank
I
you.
must go there. One day I really must go there.
It's so near. It's so near. It's
Yeah,
only
it's very
2.5
far.
hours.
So near but so far.
Oh, we have got good connectivity. Kolkata, Delhi, Chennai, all are connected. Hi, Samir.
Hi, good evening, everyone.
Bye.
What do you
Good
have in
evening.
store for us, Samir? Tough questions today?
Hi.
Good evening, everyone. Good evening, Dr. Than
Good
Than,
evening.
Dr. Faria, Vivian.
evening.
Hello, how are you?
Sorry, the minute I open my video, it all crashes, so I have to log. Hello, Samir.
Hi, ma'am.
So forgive me
Hi,
for
ma'am.
being invisible.
Oh, what a pity.
Yeah. I think we can. I think are we live, Ashmita?
Yes, ma'am, we are live.
So very warm welcome to everyone. So we have Dr. Minnie Pillai. She's part of the scientific committee, and she'll start off with the introductions. And we have Dr. Himagirish Rao. He's an endocrine surgeon. We're waiting for, of course, he's the moderator. Dr. Suresh Damodharan is the, there you are. He's the chairperson. He should be joining us soon.
Good evening, everyone.
Good evening, Dr.
Hi,
Ram.
Dr.
By the way, Happy New Year, Dr. Barua.
Yeah.
Thank you, thank you. It's Assamese New Year, so I guess it's the 10th day of
Yeah,
this New Year, 10th day.
yeah.
Ma'am, we'll start sharp at 8. Is that okay?
Yes, we will. Certainly. I
Yeah.
absolutely.
We will have
Absolutely.
the introduction to ITS first, and then we'll go ahead.
So, Shmita, do you have that video? Ashmita, do you have that video by any chance?
Yes, ma'am, we have.
I think then you play it, start playing it, and then I think that's 1 minute, some seconds. And then when it's a couple of seconds or what, I mean, when it's exactly 8, we can start off.
Namaskar. The Indian Thyroid Society is a vibrant and inclusive platform for healthcare professionals who are passionate about the thyroid. We invite you to join us and make a difference in the science, research, knowledge, care, and advocacy in all things thyroid. We have context-sensitive continuing learning programs that address the needs of clinicians, trainees, and experts alike, on-site and online. Our flagship journal, Thyroid Research and Practice, with its short turnaround and all articles ahead of print format, is an ideal vehicle for your research publications. We invite you to join, participate, network, and grow with us. To know more about Indian Thyroid Society, visit the website www.indianthyroidsociety.in. Namaskar. The Indian Thyroid Society is a vibrant and inclusive platform for
Ashmita, please
health
stop it.
who are passionate about the thyroid. We invite you to join us and make a difference in the science, research, knowledge, care, and advocacy in all things thyroid.
Ashmita,
We have context, sense.
Yes, ma'am.
please, it's enough to play it once. Can we please start off its time now?
Yes, sure, ma'am.
Dr. Suresh is asking for access to the video, and I don't think he's being allowed to be let in. Minnie, can you please take over?
Hi all. So we welcome everybody to the Indian Thyroid Society weekly clinics, thyroid clinics. So today we have Dr. Himagirish Rao, Associate Professor, Surgery, St. John's Medical College, Bangalore, to moderate the session. I welcome him. I welcome all the faculty, and I welcome Dr. Sarda Bajaj, President of Indian Thyroid Society, and I welcome all the delegates to this meeting. Dr. Himagirish Rao will now take over, and we can proceed with the session. Thank you.
Yeah, thank you, Dr. Mini. Good evening, everybody. Welcome you all to this monthly meeting module of the Indian Thyroid Society. It's my pleasure to invite our chairperson for the program now, Dr. Suresh Damodaran. He's the consultant diabetologist and endocrinologist at Sri Ramakrishna Hospital, Coimbatore. As it happens, I'm right next door. I'm in Erode, so maybe I can just jet across and say a hi to him. As it stands, let me invite him to come along and introduce our speaker, Professor Vivian Lim from Singapore. Dr. Suresh, over to you. Is he there? Yeah, he says that he can't access. Anyway, while they're not allowed. I think while we set right that little glitch, I guess it's sort of prudent to not waste time and go ahead with our program. Let me invite Professor Lim from Singapore. She's the president of the ASEAN Federation of Endocrinological Societies, and she works and practices from Singapore. We are privileged to have you for today's talk, dear ma'am. Over to you. Please take over and hope for an academic feast for the next half an hour.
Oh, thank you very
I'm
much.
sure it's an interesting topic, and there would be questions, I suppose. So we can take questions at the end of Dr. Lim's talk. Over to you, ma'am.
Thank you very much for the kind introduction. I'm just going to share the screen now, and
Yeah.
hopefully this doesn't go wrong. Okay, here we go. So can you hear me well?
Yeah,
Yes, we
crystal
can.
clear.
Yes, we
Very
can,
good.
Vivian.
Very
We can hear
good,
you, and we can see
excellent.
your slides as well.
Control alternate shift H. Right, control. Okay, let's go. I'm going to turn off this thing. Okay, and you can see my cursor here, right?
Yes, we can.
Okay, well, I'd like to thank Dr. Sarita Bajaj for asking me to give this talk. She's a lovely lady, lovely friend. So when she says, could you do this talk? I said, sure. It's 10:30 p.m. now in Singapore, so a good night to you guys. And I have to say that this is no disclosures of mine, none relevant for this talk. I've Googled this and I said, okay, let's start with what's the definition of controversy. So controversy is a disagreement, often a public one, that involves different ideas or opinions about something. And I went, whoa, controversies in hypothyroidism. It's a very, very large topic, given that I only have 30 minutes. And I'm sure you don't want me to be talking too long as well. I thought I'm just going to curtail it down and focus on the clinical aspects, giving basic principles and clinical principles and polls. And at the same time, now I'm not going to go and focus on pregnancy, because I feel that that needs to have its entire whole 30-minute session just to talk about all the controversies about pregnancy. But perhaps you could ask us later in the panel with regards to questions about that. So the objectives, I'm going to establish a baseline. We're going to discuss controversies regarding analysis of a baseline thyroid test results. Now, then when to initiate treatment for hypothyroidism, what is the level to treat to, and the dastardly T3 and T4 combination. So then we will start with, I like basic principles, I like, simple things first. So however does the thyroid look like? I'm sure you all know this, and I'm very sure I'm insulting your intelligence when I show you that little thyroid. I think it's pretty sexy, very nice little thyroid gland in front of the anterior neck. So that's how a thyroid looks like in ultrasound. I have an ultrasound machine. I have 2 ultrasound machines sitting in my clinic, and it's fun to correlate them. That's your thyroid gland. This is the right thyroid lobe, carotid arteries, jugular vein. Here is the left, and you've got the right, well, that's not the right, that's the left lip. And you have got the trachea, the isthmus, and this is the esophagus. That's the thyroid nodule. That's how a thyroid nodule looks like on an ultrasound. And this is a multinodular goiter, and how a multinodular goiter looks like an ultrasound. Solid, this is cystic. Now, this is how a right thyroid transverse view looks like. And this is homogeneous, and this is normal looking. This is how an inflamed thyroid looks like. And you can see it in Hashimoto's thyroiditis. And so that's how it looks like. This is with vascularity. This is a normal vascularity, but can you see a glaring big little hole sitting down there? That's the thyroid cyst sitting out there. Let's go through this. So this is the thyroid pituitary and hypothalamus axis. Now in endocrine, we have lots of axes with the adrenal and pituitary axis, and hypothalamus, pituitary, and adrenal axis, and they all follow the same pattern. So I'll more or less, hypothalamus, TRH, thyroid releasing hormone, goes to the pituitary, thyroid stimulating hormone goes to thyroid gland, produces, and the thyroid gland produces T3 and T4, feeds back to the pituitary, and they all feed back and live in harmony. So all of them should be black in color, no red marks, nothing should be out of the reference range in general. So what's the most sensitive thing about this first is the TSH. So the TSH is a very, very sensitive marker in which you will go up and you will go down if it's a primary thyroid disorder, in order to keep the T3 and T4 normal. So let's see if there's a T3-T4 is increased, a TSH is low. This is a primary thyroid issue. It could be graves, it could be thyroid nodule, it could be exogenous thyroid. But in general, let's say we're talking about endogenous causes. If it's a primary thyroid issue, the TSH must move first. So you have clinical hyper, and then you have overt hyperthyroidism. Similarly, if you're talking about hypothyroidism, and it's the primary thyroid disorder, such as Hashimoto's thyroiditis, such as surgery, total thyroidectomy, the TSH goes up high first, and then the free T4 starts decreasing. So you've got subclinical hypo, and then you've got overt hypothyroidism. So I want to then address this issue of what happens then if you see a free T4 which is increased and the TSH is normal. because the vast majority of endogenous thyroid issues are always primary. Sometimes we get referrals to us, I'm an endocrinologist, and saying that, this patient has a hypothyroidism, and we started treating with hyperthyroidism, started treating with carbimazole, please assess for Graves' disease. But let's say if you have a free T4 which is increased and the TSH which is normal or TSH which is high. Now this is inappropriate because the most sensitive marker is that of the TSH. The pituitary senses a perturbation in the T4 and T3. And before it can even move, the TSH logarithmically moves down. And similarly for the hypothyroidism, if it senses any perturbation, you're going to see a correspondingly increasing TSH. It slowly increases, and it has to increase to a certain level, 10 above, before we really see any clinical decrease in the free T4 levels. And therefore, if you see a TSH which is normal, if the free T4 is decreased, we're talking about an inappropriately normal TSH. The problem does not lie with a primary thyroid issue. Look elsewhere, and certainly not if the TSH is low. So that's when you look out for. And that's the controversy in terms of using loosely a controversy, meaning disagreement, in which is sent to me, thinking is a primary thyroid disorder. But I disagree. I feel that there's something else going on because the TSH has not gone the other way. So let's take a look at Ms. SM, move on to some clinical cases. She's 42-year-old executive. She complains of tiredness. She requires more energy output to keep her weight. Her weight is neutral. Her free T4 is rock bottom low at 0.1. The lower limit of normal is 0.93. The TSH is 140. And while the upper limit of normal, as you know, is 4.2. This is without doubt overt, frank hypothyroidism. I have no doubt that the symptoms are there. This is how it looks like. The right thyroid is heterogeneous. It's not smooth there. And this is very small. It's quite a small thyroid. This is the left thyroid, also not smooth, quite translucent already, hypoechoic looking. It's increased in vascularity now compared to previously. That's being attacked by the antibodies. And here's the antibodies, the anti-TPO with 1,875. Upper limit is 5. So this is Hashimoto's thyroiditis, no problems. We treat them, started her on 100 micrograms of T4. She felt much better. TSH all went down to a proper range, about 2+. Now, this is Miss HHB. She's 42-year-old female. She was referred for hypothyroidism, weight gain of 5 kilograms over 3 years, feels tired, not better even with a thyroid treatment. Now, these are her results. I want to pause here a little while to let you take a look at the results. So the free T4 is low, the TSH is low, antibodies are positive. What is the diagnosis here? If this were a primary thyroid disorder, this is a red herring. If this were a primary thyroid disorder, my TSH must go up first because it senses it and it will start going up. So what's happening here? I don't think this is the cause, even though the antibiotics are positive. She might genuinely have Hashimoto, she might genuinely have an antibody which is positive, but it does not translate to, it might not be hypothyroidism. It might be just euthyroid antibody positivity. So there's something wrong here. She falls into this category. So I think then about things like drugs like steroids that can suppress the TSH, sick thyroid syndrome or non-thyroid illnesses, which is not exactly the thyroid's fault, or pituitary or hypothalamic disorder, like a huge pituitary tumor that can actually cause a suppression of the TSH because it's impinged because of the mass effect. The MRI pituitary was normal. This is the other axis that I want to bring in. The cortisol was 606 at 8 a.m. in the morning. And overnight suppression means I give external steroids at 11 p.m. and the next day it doesn't budge. The steroids doesn't cause, if without any issues, the steroids, the cortisol at 8 a.m. should go down to less than 50. So this is not suppressible. And the ACTH is low. It's the same axis that we see, except that instead of the pituitary gland, you're going to see the adrenal glands, and this command hormone is ACTH. So the cortisol here is being, if the ACTH is low, it means that if it's a primary adrenal disease, there is an autonomous production of cortisol. Where's the problem now? Can you see that big whopping tumor? So that's a left adrenal tumor. Status post left adrenalectomy, she lost all her weight back to baseline, and the thyroid hormones all normalized. So in this case, this was actually Cushing's syndrome, and the steroids can actually cause a pituitary thyroid axis dysfunction. So this was not a primary thyroid disease. And actually, we more or less knew. The CT scan was done together with the MRI pituitary. We were just trying to be very, very cautious because we wanted to make sure that there was no concomitant two issues happening. Okay, but there we go. So what are the goals of thyroid SIN replacement? Now, thyroid SIN replacement therapies have three main goals. They are to provide resolution of the patient's symptoms and hypothyroid signs, including biological and physiologic markers of hypothyroidism. Now, this first aim is going to create us a lot of problems, and you'll see more later. Number two, to achieve normalization of serum thyrotropin with improvement in thyroid hormone concentrations. This is, which means within the range. Normalization means within the range of TSH, and to avoid overtreatment, especially in the elderly. So when do we initiate replacement? Remember this lady, the first case. This is overt hypothyroid. Overt hypothyroid. I think someone has to mute the. Yeah. So this is overt hypothyroidism. We have no problems. We know that we have to treat, and when we treat, all symptoms will have resolved. Now we go to Miss AP. It's a 32-year-old. Can we have a, somebody has to mute that. Thank you. So this is Miss AP. She's 32 years old. No family history of note. She complains of fatigue. Weight gain 10 kilograms since COVID started, about 2 years. The current BMI is 35.1. Height is 1.6 meters. Weight is 90 kilograms. Look at her VT4, which is 12. Lower limits 10. TSH is 1.2. Upper limits 4.5. Antibodies are normal. My question for you, what do you want to do? I have many patients coming to me, and I'm sure you guys out there have the same. We've got coming to you and they tell you that, look, I'm very sure I have a thyroid problem because I've got weight gain. I cannot explain. I don't eat a lot, and I'm tired. So what if the antibodies were high? Does it change your management? And then what if the TSH were 4.0 and the VT4 still stays the same? Remember, the TSH moves first because it's the most sensitive marker, yeah? So VT4 can still stay the same at the TSH of 4. What happens if the TSH is 6.0? VT4 still stays the same. Would any of this change your management? Now we're going to discuss this then. So which level of TSH to initiate replacement? Certainly you've got controversy about this. Lots of discussion, lots of debates, different practitioners having different views. Let's know what are the data that we have. Coronary heart disease risk increases when the TSH levels are more than 10. Upper limit of the TSH reference range is in general between 4.5 to 5 internationally. TSH levels trend higher in the elderly. Without thyroid disease, 10.6% of 20 to 29-year-olds have a TSH which is greater than 2.5, but this increases to 40% in the 80-year-old group, and 14.5% of whom had TSH which greater than 4.5. And the 97.5 fifth centile was 7.49 in the elderly group and about 80-year-old group. At the same time, obesity itself is associated with a higher TSH level. So if you take a look here, with the study for about 4,000 patients between underweight, normal, overweight, obesity, and morbid obesity, the median TSH increases. Let's take a look at the 2.5 to the 97.5th percentile. Okay, that's normal range, yeah? So if you look at morbid obesity, I don't like the term morbid obesity. This refers to BMIs which are more than 40. The lower limit is 0.69, but the upper limit is 7.5. What about those who are obese? So this would probably be class 1, class 2. The upper limit is 5.94. And the overweight, The upper limit is 5.51. Okay, so not much difference between the overweight to the normal weight ones, and the underweight is 4.81. So this group of people then seems to be slightly higher. What is so just looking by it, you would think that, okay, so great. So then there's something wrong with them. We should treat them, right? Because it is because of the higher TSH levels, subclinical hypothyroidism, which is causing it. Let's take a look at this then. This is bariatric surgery data in which we had weight loss and the mean TSH before and after. And every one of them, in general, the TSH drops after weight loss. So in other words, obesity is the cause of the higher TSH. It's not the other way around. So we must be very clear when we're looking at observational data that it's not causation. You want to know cause, we need trials, we need randomized controlled trials. So back to Ms. SM, obvious, no questions about this. We're treating this. And I just wanted to show you with regards to the weight. Now, when we treated her at the TSH of 140, we treated her with 100 micrograms, it went down. She went down, it's about like 4 to 5 kilograms. At this point in time, she was actually perfectly euthyroid. TSH was within range. And then her weight started climbing up. See, weight is not simple. This lady, remember her, she had Cushing's and she had central suppression of TSH. How much kilograms did she increase? 5 kilograms. Back to her, Miss AP. So she increased by 10 kilograms. With a 3T4, which is 12, and a TSH well within limits. With this TSH, I sent for pregnancy. And she insists that if she insists that she has fatigue and her weight gain, it's because of hypothyroid. I would beg to disagree. I wouldn't start treatment for her, not for this. Now let's say if her antibodies were high, doesn't matter whether antibodies were high or not. The TSH is perfectly normal. That's the most sensitive marker. It's sitting beautifully at 1.2. Now let's say she's BMI 35.1. So if using Asian standard, that's class 2 obesity. So what if the TSH is 4.0? The free T4 still stays the same. I still wouldn't treat her because it's still within range. Now, what about if the TSH is 6.0 and the free T4 still stays the same? Well, this is going to be difficult, because they're expecting and they're looking at the range and they go, look, it's red. The upper limit is 4.5 and they're going to latch onto that. But at this point in time, I think it's very important that we manage expectation and we also see what is the complaint. And if a complaint is fatigue and weight gain, I'm going to bet you that I gave you, even if I gave you a thyroxine enough to go for 1.2, it's not going to budge. It's not going to budge much. So weight is not that easy, especially if many come complaining of it. And that's the vast majority of patients when they come in insisting they have hypothyroidism, they complain about it. So patients with thyrotoxicosis can gain weight. Patients with hypothyroidism have lost weight. Patients with euthyroidism who gain weight, and patients with euthyroidism and gain weight, and then they insist that they have thyroid issues. So what does the ATA 2014 hypothyroid guidelines say? We recommend against the treatment of obesity with levothyroxine in euthyroid individuals due to lack of treatment efficacy for this condition. What about fatigue and well-being? So I'm just going to move on to this one first, which is a bigger trial. So what's the effects of altering levothyroxine doses on quality of life, mood, and cognition in thyroxine-treated subjects? So this was a randomized controlled trial of 138 subjects with T4 treated hypothyroidism, normal thyrotropin levels. So they were randomly assigned to receive an unchanged, a higher or lower LT4 dose in a double-blind fashion, very important double-blind fashion, targeting one of the 3 TSH ranges, 0.34 to 2.5, 2.5 to 5.6, and 5.6 to 12. Those doses were adjusted every 6 weeks based on the TSH levels, and the baseline measures were reassessed at 6 months. So at the end of the study, the mean T4 doses were 1.5, 1.32, and 0.78 micrograms per kilogram. And the mean TSH levels, if you look at it, 1.85, 3.9, 9.49 milliunits per liter, respectively in the 3 arms. Were there differences? None. But the interesting part is this. the subjects were not able to accurately ascertain changes in LT4 doses. However, the majority preferred whichever LT4 dose they thought was higher. So when it comes to subjectivity, and that we're having lots and lots of problems, when one of the objectives of thyroid hormone replacement is symptoms or purported symptoms of hypothyroidism, which is very non-specific. So when we go back to this again, so let's talk about, because we talk about weight. So we discuss about weight, and if that's her expectations, we have to meet her expectations and to caution her that giving that for even for 6 might not help with anything. And in fact, obesity is the cause of an increased TSH, and going down the weight might actually decrease the TSH. Number 2, what about fatigue? So we gave data to show that perhaps it might not also be the best yardstick of whether we should replace or not. Now, I have no qualms in starting because there's minimal risk if I started giving 25 micrograms, let's say. But this is going to be an escalating game if their needs are not met and we have bought into what they thought was the problem, which is that they had hypothyroidism, which is causing all the fatigue and weight gain. So now let's say you have initiated treatment. This is a truly Hashimoto's thyroiditis patient. She might be obese with a BMI of 35.1, but well, she's Hashimoto's thyroiditis, high overt hypothyroidism. You started her treatment. And what's the question now is, how low do I push the TSH down to? Again, the goals of treatment, these are the goals of treatment. You have achieved normalization. We have achieved avoiding over-treatment. But this problem, the first aim eludes us because she still says, let's say if she still says that she has apparent complaints of hypothyroidism. So I've made the scenario in which we said that she's Hashimoto, she's frankly hypothyroid. I've placed her in 100 micrograms before. Now we've got 3 T4 of 12, TSH of 2. She's lost 1 kilogram. She still feels tired. She says the weight loss is not enough. She is hypothyroid. She is still feeling hypothyroid. What do you want to do then? Can the TSH be pushed down further? My next question would be, why do you want to do so? This is Miss AT. She's a 32-year-old Indian female. She came to me 2 months ago. She just came to Singapore 1 month prior to me seeing her in February, so in January. She complained of losing weight, 10 kilograms, 57 kilograms in 6 months. She said she was told that she had a thyroid problem previously, was treated, wasn't sure what it was. She was not tired. She was not stressed. She says she's eating. Guess what her T4 levels are and the TSH levels. So T4 is 13, TSH is 7.5, anti-TG, anti-TPO is high. This is Hashimoto's thyroiditis. This is subclinical Hashimoto's subclinical hypothyroidism. She lost 10 kilograms. On further questioning, her first baby was born 9 months ago. She lost from 62 kilograms to 57 kilograms 6 months prior to this. That was about 5 months prior to coming to Singapore. And then since then, she's just kept losing. She said she wasn't stressed. She said she wasn't tired. I asked her, do you handle stress by not eating? She says yes. Certainly when you lose 10 kilograms, the input must be less than the output. While she was in my clinic for the half an hour for the first consult, she was holding a baby and she was jumping over the place. She was like a little dynamo. There was no symptoms at all of hypothyroidism, and she subjectively did not feel tired, and she subjectively did not feel stressed, and she subjectively thought she was eating. But you don't lose 10 kilograms without doing that. And then when you question further, and the husband was there as well, and you realize that she was stressed. A reasonable person would be stressed if you came over to Singapore 1 month prior, you had a baby which was born 9 months beforehand, and it was your first baby. And then you have to spend the 5 months before that trying to pack to come over, uproot everybody else to come to Singapore. So the moral of the story for this is that it's not the TSH levels. Everything is subjective at the same time. And also, please come over to Singapore because you can lose 10 kilograms just by the thought of coming over to Singapore. So this is the law of diminishing returns. We know
excuse
that.
me, Dr. Lim.
Yes.
Very sorry to interrupt. This is very, very interesting, very spellbounding presentation of yours. It deals with a lot of problems that we deal with in our everyday practice. but I must call your attention to time. It's a minute left for 8:30, and
Okay.
having a panel discussion
Sure,
coming up next.
Sure. Can you
There are
give
a
me
couple of
about 5 more?
questions. Yeah.
Yes.
Yeah.
Can you give me about 5 more minutes more?
Yes, yes, we can.
Yes, thank
Absolutely.
you.
Please go ahead. Thank you,
Thank
Dr.
you.
Rao.
No problem.
Thank
Hi.
you for being the timekeeper.
you.
Thank you so much. Please
Being
go
the
ahead.
bad cop, you know.
5 minutes. Absolutely.
Oh, yeah, sorry, 5 to 10. Sorry.
No, not at all. Not at all.
Yes.
We started 3 minutes late, if I'm not wrong.
Yes, correct.
Yeah.
Yeah.
So, okay, so I'll try to finish in 5 to 10, all right? So now let's go back to this patient. So she's complaining of the same thing. And again, we are going to manage expectations, and we have to allay that her misconceptions and discuss misconceptions of what thyroid hormone can help her with. So now let's say we've increased to 125 micrograms. Free T4 is 12.3, TSH is 1. There's no weight loss. She's still feeling tired. And she tells you this dreaded sentence. My friend tells me, I read on the internet. T3 is very good, and I like it. So now we're going to talk about T3 and T4 combinations. So then my question for you is, if the TSH is within range, TSH is 1.0, why are you thinking of using this? Again, it's all about expectations, about conceptions about what thyroxine does and what are the symptoms. Why do many people think about T3? I'm going to skip over this because in the panel discussion, we can discuss this at the same time. That was one of the questions that we'll be answering, okay? So just suffice it to say that people think about it physiologically, that we have T3, and they think that we should actually do it. And if the free T3 is low, but the free T3 assay is not very reliable. So this is a meta-analysis of T3 and T4 combinations. And we've got 11 studies, 1,216. To cut the long story short, no difference was found in the effectiveness of combination against monotherapy in any of the following symptoms, be it bodily pain, depression, anxiety, fatigue, quality of life, body weight, total serum cholesterol, triglycerides, LDL, or high density lipoprotein. And most of the studies we're using are concerning supraphysiological T3 or T4 ratios. And the conclusions the author gave was that T4 monotherapy should remain the treatment of choice for clinical hypothyroidism. Now, because in the interest of time, just to give this, the reason why I put this case up was she's it's a cautionary tale. She's 30, she's about 30 years old. Started 3 years ago already. She complained of difficulty maintaining weight, fatigue, menstrual irregularity, hair loss, feeling cold, obvious supposed hypothyroid symptoms. Her first T4 and T3, TSH, was totally normal. She's 52 kilograms, she's 1.62 meters. Her current T4 is 32. Her TSH is rock bottom low. She's a 52 kilogram lady who her initial T4 and TSH was totally normal. The TSH, I remember, was 1+. Her T4 now, the thyroxine replacement she's on is 125, and the T3 is 25 micrograms. She has frank thyrotoxic symptoms of mild tremors, mild proximal myopathy. Every time she started this 3 years ago, she was placed on 25 micrograms. She felt better for a few months. Then the symptoms recurred, and then they were escalating doses to the dose currently. So if I go back to this lady, and then we're going to discuss with her that you already know my thoughts about treating for a TSH of 1.2. The answer is no. This one possible because it's very difficult to argue her down, but you have to make sure why you're treating. And if it doesn't go down further, you are not going to enable it and continue treatment. Now, let's say if it's positive and it's 2, you still go down to 1.0, I wouldn't add on a thyroxine replacement. I keep putting now here an excess weight of 31 kilograms. I'm going to put to the audience, that if you have a 31 kilograms excess weight suddenly now, how are you going to feel after 1 day? You're going to be fatigued. You're not going to feel good. You're going to have aches and pains everywhere if you've got the excess weight. So that is something that we must also discuss in terms of that, because a lot of people come in complaining of this weight. So this might be the cause of everything else. So the conclusions, we went through a few controversies. We talked about interpretation of thyroid blood tests, and that's good to know because we're also going to talk about central hypothyroidism in the panel. So remember that the blood test, if it's primary, your TSH should go up, if this is hypothyroidism. When to initiate treatment, that's a controversy as well. In terms, we know 10, yes, because of cardiovascular. We know less than 5, that's actually within range. Everything in between, that's a toss-up, especially if you are elderly, especially if you're obese. This also is associated with a higher TSH. So which means that the TSH is not the problem of whatever the complaint was. We talked about TSH and weight. We talked about TSH and other symptoms in terms of blinded tests, in which we showed that it didn't seem to feel much difference, even as high as the TSH level of 9. We talked about how low to push, and T3 and T4 combinations. So I think to treat the patient as a whole and to manage expectations and to address and correct any misconceptions, and at no cost, at any cost, we should avoid enabling them such that they go higher and higher and higher and go frankly thyroid toxic. I've seen people being admitted before. I've admitted people before for frank hypothyroid toxicosis, and they refuse to budge on their T3. And here's our little thyroid, which is one of the most maligned gland, I feel. And so be kind to our thyroid gland, because it's always being hanged and it's always being blamed for so many things. Well, just to welcome you to Singapore virtually at our International Congress of Endocrinology, twinned with AFES as well as Asia Oceania. So I hope to see you there virtually. Unfortunately, there won't be physical. You can scan this at our main Congress website as well. And thank you very much. Sorry for taking a little bit more of your time. Thank you, and I'll answer any questions. And if I can't answer your questions, you can email me.
Thank you very much for that very crystal clear talk, Dr. Lim. In fact, I feel I could listen to you all day. The way you address these controversies and the way you've been very categorical and very frank and very clear in addressing these and letting us know about what you feel about them. Thank you very much. And I'm sorry to be calling time on this. I'm sorry to be the bad cop. As I said, I could listen all day. A couple of quick questions. Dr. Barua asks whether the TSH level, high TSH level in obesity, is it a physiological adjustment to maintain BMR? Because BMR is higher in obese people. That's one. Another question, Dr. Divakar Verma is asking, should the dose of thyroxine be dictated by the dose of the level of the baseline TSH of the patient? These are two questions.
So which was the first question was in obesity, whether that was a physiological response. So
Yes.
We don't know 100% why is it. That might be one of the reasons why it is so as well. Yes. As for the dose of, what was the second question again?
The dose of thyroxine as a function of the baseline TSH level. Somebody with a TSH 200 and somebody with a TSH of 10, will the initial doses change?
I see what you say. Okay, yes. So it really depends how much I start thyroxine on. Let's say, for example, the first patient, Miss SM, where was frank hypothyroidism, TSH was 140. Yeah, her weight was, if I remember correctly, 68 kilograms. I just gave her 100 micrograms. Now we go by about 1.6 micrograms per kilogram. I have to confess, I stopped counting that. I just ballpark look at the person and I'll go 100 micrograms. And I find that most patients who are within a certain weight, between 50 to 80, 90, even 100 micrograms seems to be the sweet spot. And then we will adjust from then onwards.
Okay.
But obviously, I mean, the common sense is that if someone starts with a TSH of 10, I'm not going to give 100 micrograms. And if a TSH of 10, she's 200 kilograms, I might want to start with 50 or even 75, depending on, the weight and the TSH levels.
Right. That's what we are also taught. It's more the requirement per kilo body weight of thyroxine matters. Thank you, Dr. Lim. Thank you very much for your talk. Let me hand over the moderator's position to Dr. Samir Agarwal, Head Endocrinology and Metabolism, Apex Plus Super Speciality Hospital, Rohtak. Over to you, sir, for moderation of the panel discussion on hypothyroidism.
Thank you, sir, for nice words, and thanks, Dr. Lim. I think it was a crisp and a very informative presentation. Thanks to Dr. Sarita Bajaj. I think hats off to her energies right from inception of this webinar and coordinating the events. Thank you, ma'am, for leading from the front. Thanks to all the seniors who have joined as panelists throughout Southeast Asia. Thanks to our audience who have taken their time out of their busy schedule for today's evening. We have Dr. Thanthan Ai, Dr. Faria Afsana, Dr. Vivian Lim, and Dr. Manas Barua as panelists for this session. Dr. Thanthan is from Myanmar. Dr. Faria Afsana is from Bangladesh. Dr. Lim doesn't need any introduction. She's from Singapore. And Dr. Manas Barua, very good friend of us from Assam to the eastern part of India. I think East is predominating in today's webinar. So welcome all of you. I think audience have some overlapping questions also as we have put in our panel today. But I would like Dr. Thanthan to discuss about our first panel question. So we have been encountering hypothyroid patients routinely in our clinics, ma'am. So how do we define overt hypothyroidism and subclinical hypothyroidism? A basic question for you.
Thank you, sir. And thank you for inviting me for participate in this panel. Actually, overt hypothyroidism is defined by the increased level of thyroid stimulating hormone with reduced circulating levels of free thyroxine, free T3 and free T4. Whereas subclinical hypothyroidism is defined by increased TSH value in face of normal circulating free T3 and T4. The most common causes of hypothyroidism are actually Hashimoto thyroidism, followed by ablation of radioactive iodine and surgery, and post-radiation of the head and neck, and drugs such as immunodrone and so on. And prevalence of hypothyroidism and subclinical hypothyroidism varies with different countries. I think hypothyroidism is more prevalent in our part of the world, according to the literature, stating that the prevalence of hypothyroidism in India is 11% compared to only 2% in UK and 4.6% USA. So in Myanmar, I also found that the hypothyroidism more and more common, probably due to the impact of the iodization program since almost 20 years now, having more and more cases of hypothyroidism we encountered. And aging also is an important factor for hypothyroidism, and the most frequent endocrine disease in the elderly and female, and it's found that TSH level also raised in more than 80 years old. So
Thank you.
Thank you.
Okay, so yes, it's very important to diagnose whether it is subclinical hypo or it is a frank hypothyroid, because the treatment is very clear once it's a frank overt hypothyroidism. And in fact, population-based studies have shown the prevalence of subclinical hypothyroidism ranging from around 4 to 15%. And it increases, the subprevalence of subclinical hypothyroidism, as told by ma'am, increases with age, may be higher in females than males. Interestingly, if the iodine intake is variable, then subclinical hypo, particularly there has been some data from Europe, which has shown that maybe subclinical hypothyroidism is more prevalent in areas of iodine sufficiency. So that's very interesting. So why is it so? I think we'll have to go to the next panel question to be answered by Dr. Lim. Ma'am, we know that iodine intake can cause both hyperthyroidism as well as hypothyroidism. We have seen patients taking some drugs like amiodarone landing up into hyperthyroidism, or toxic nodular goiters. If they are exposed to iodine, they can land up into hyperthyroidism. But what is the relationship between iodine and hypothyroidism? Can you unmute, ma'am?
About that, yes. So to do that, I always like to go back to basic principles first. When you take iodine, And when you take iodine, what does it do? We are iodine-rich nation in Singapore. What do I use iodine for? I use it for thyroid storm patients. How? Because when I give thyroid storm, sodium iodide, glucose, potassium iodide, what it does is decreases secretion first of thyroxine from the thyroid gland itself. And number two, what it also does is decreases thyroid hormone synthesis. So what happens then is that after 2 or 4 weeks, a few weeks later, for normal thyroid glands, we escape this. So that's a Wolff-Chaikoff effect. But the problem comes then if you have an abnormal thyroid gland, which has some degree of autonomous production of thyroid in the tissue. For example, very iodine deficient nations, where there might be nodules there, 30% will have nodules, there might be autonomous production, there's latent grays. The minute you give them iodine, which is the substrate for thyroid hormone, you're going to be having unimpeded hyperthyroidism. But if you give iodine similarly to patients who are autoimmune thyroiditis, for example, those with antibodies, there's something not quite right there. What happens is they cannot escape for this suppression. So if they can't escape, you end up then with permanent hypothyroidism. And therein lies the problem that we see now with this supplementation. And there's a higher prevalence now in patients in countries where they are iodine depleted countries, like for example Singapore, especially if you give them amiodarone, because there's quite a high dose of iodine inside 100 milligram a tablet of amiodarone.
Yeah, I fully agree. And in fact, very rightly said by Dr. Lim that those patients who have some underlying autoimmune thyroid disease like Hashimoto's thyroiditis, maybe these patients are at risk for iodine-induced hypothyroidism. Other conditions like postpartum thyroiditis, some patients undergoing radioactive iodine ablation for Graves' disease, maybe they are also at risk for iodine-induced hypothyroidism. Dr. Lim, do you have this experience of patients of amiodarone landing up into hypothyroidism?
Hyperthyroidism, yeah, we do have that. So now all our clinics, all the cardiologists starting with actually discuss it with the endocrinologist at the same time, because we are mindful of the fact that we have to do the baseline thyroxine beforehand, the free T4 and the TSH, and then doing treatment at the same time. So
yeah. Interestingly, since amiodarone, this has a very high iodine by weight, and it can be a long-lasting exposure after amiodarone. And in some underlying conditions, you cannot stop amiodarone. So it can occur early on, it can occur at a later duration also. So you have to be vigilant once the patients are on amiodarone that they do not develop hypothyroidism. So thank you, ma'am, for your observations. So yes, you can have subclinical hypo and frank hypothyroidism. Also, we all know that frank hypothyroidism can practically affect all our body organs. But whenever we encounter these subclinical hypo patients, we are worried that how are they going to disturb our metabolism? So I put to Dr. Faria this question: what can be the consequences of subclinical hypothyroidism?
Thank you for the question. I like to thank Indian Thyroid Society and Professor Sarita Bajaj ma'am for inviting me as a panel of experts. And next, come to the question about the consequences of subclinical hypothyroidism. Actually, the burning question is whether to treat or not, because many of the subclinical hypothyroidism are transient even, and some progresses to overt hypothyroidism. So we must consider which patients are progressing to overt hypothyroidism or who are transient. Actually, it is sometimes not well defined, but there are some risk factors for progression of overt hypothyroidism. Patients' iodine intake status, previous history of thyroid disease, or the TSH level. Actually, if the level is around 10 or high, in that case, there is chance of progression. And the antibody positivity, TPO antibody positivity, is very high chance of progression to overt hypothyroidism. But while considering the incidence of subclinical hypothyroidism, though it varies from different studies, there is around 25 to 30% chance of recovery rate of the subclinical hypothyroidism also. So while starting treatment, we must be very cautious about the subclinical hypothyroidism, whether or treat or not to treat. So TSH may fluctuate, as we hear from Dr. Lim, that many other factors, external factors, are responsible for drugs. Some seasonal variation, that is cold environment, steroid, obesity, are some factors which may alter the TSH level. So consequences of subclinical hypothyroidism actually depends sometimes in the risk factors also. So while there is antibody positivity and the TSH level in the higher range, then we must treat so that we can avoid the overt hypothyroidism. Otherwise, we may wait for a few months to recheck the thyroid function, and the antibody positivity then can start.
Thank you, ma'am. I think, yes, we have been hearing that subclinical hypo can progress to overt hypothyroidism. It can be associated with reproductive abnormalities, neuropsychiatric symptoms, some muscular symptoms, and recent cross-sectional studies have shown some association with NAFLD also. So I think we should be vigilant about all of these things once we are encountering patients of subclinical hypo. So as Dr. Faria was saying, the burning question is treatment of subclinical hypo, and we encounter many prescriptions as endocrinologists, patients on thyroxine, and when you dig out the reports, TSH was around 765, and patients have been on thyroxine for years together. So do they need treatment? So I put this question to my friend, Dr. Manas. Thank you, sir, for joining. Indications of treatment in subclinical hypothyroidism.
Thank you, Samir, for this question. It's very important. I think the dictum of not treating a report and not treating a disease, rather treating a person is I think, quite valid in the field of hypothyroidism treatment, especially subclinical hypothyroidism. I'll give you a few hard indications where there is unequivocal benefit. One is THS more than 10, irrespective of age, there is unequivocal benefit. We should treat irrespective of the baseline free T4 or T4 level. Of course, when it is between 4.5 or 4.2, whatever you consider as upper limit to 10, then there are some controversies. Of course, here again, if you have significantly high titer of anti-thyroid antibody, or a lady planning pregnancy, or a lady having bad obstetric history in the recent past and having infertility, that is a group where you should try to treat. You should treat and try to bring down the THS to the level of 2.5. And the third indication, of course, would be association of thyroid enlargement, goiter. We must treat this group of patients having 4.5 to 10. Okay. And of course, there are some other softer indications where we should be vigilant and treat, not to overtreat, as Dr. Lim has said. We must bring down the THS level to normal, not overtreat, because that can cause various side effects. So what are those groups? Yes, one could be psychiatric disorders where treatment may benefit, and two, a patient having high cardiovascular risk, especially if the THS is more than 7 and the person is less than 70 years, there is definite indication of benefit. Of course, if the person is more than 70 years, the cardiovascular benefit by giving thyroxine treatment when the THS level is between 7 to 10 is little doubtful. In fact, sometimes it may cause deleterious effect. And of course, lastly, sometimes for repeated elevation of THS where the patient's quality of life is going down, then we may give a trial of thyroxine and look very carefully. You should not overtreat, keep the THS somewhere around 2.5 to 4, and T4 should never exceed the upper limit of normal. In that scenario, probably many times your patient might get benefit. I would say these are the few indications which a clinician should be treating subclinical hypothyroidism.
Perfectly answered. I think, yes, these are the clear-cut instructions, and we should not be over-treating subclinical hypothyroid patients. And sometimes we have seen patients, especially there was a data published in JCM 2009, I think, 40% patients over 65 years of age who were taking thyroxine had subnormal TSH. So we should be very clear which patients group to be treated. So thank you, Dr. Manas, for your expert comments. So we are clear with many concepts of subclinical, overt hypothyroidism, iodine, and this. So another entity which we are encountering, of course, rarely is that central hypothyroidism. It's not only primary hypothyroidism which we encounter, but yes, central hypothyroidism. So I put this question again to Dr. Thanthan. Ma'am, how do you diagnose central hypothyroidism?
Yes, sir. Central hypothyroidism is caused by the pituitary or hypothalamus, and it is due to insufficient stimulation of TSH of the otherwise normal thyroid gland. So diagnosis is usually made biochemically with low circulating free T4 concentration associated with inappropriately low or normal serum TSH level. Isolated central hypothyroidism is rare, but central hypothyroidism is most frequently diagnosed as a consequence of the biochemical assessment in patients with hypothalamic and pituitary lesions. So central hypothyroidism must always be suspected in patients with hypothalamic and pituitary disorders. There are some factors hindering the correct diagnosis in assessment in the diagnosis of central hypothyroidism, such as methodological interference in free T4 and TSH measurement, which must be excluded if in doubt. Routine utilization of total T4 and T3 measurements is also hindering in the diagnosis, which can be missed because of TBG abnormalities. There are some other conditions presenting with similar biochemical features, such as concurrent systemic non-thyroid illness that is characterized by low level of free T4 and low normal TSH concentration. And also the drugs inhibiting the TSH secretion like glucocorticoids, dopamine, cocaine, anti-epileptics, and antipsychotic drugs, which can also make it confusions. And another problem is the screening program policy. The usage of the TSH reflex strategy, which is measurement of the sole level of TSH without free T4 measurement in the screening process, can miss their central hypothyroidisms, especially in the neonatal screening of the screening of thyroid function. Without testing the free T4, and if the thyroid TSH level is normal, we can miss the diagnosis. In the diagnosis, I would like to mention a bit briefly about the dynamic test, like a TRH stimulation test is sometimes can be useful, but it's rarely used, where TSH measurements serially post TRH at 20 and 60 minutes. Normal response is 20 minutes is higher than 60 minutes. If there is a delay or flat TSH response, the diagnosis of the central hypothyroidism can be made. And other tests which can be useful are the genetic testing, which is used for the familial or congenital central hypothyroidism. So central hypothyroidism diagnosis is challenging and due to a lack of very accurate clinical and biochemical pictures. Thank you.
Thank you, ma'am. I think very well illustrated. Any patient who is suspected for central hypothyroidism, we must rule out any concomitant pituitary hormone deficiencies. I think we must do a serum cortisol at 8 a.m. So that's the usual thing. But of course, you can have all other things. And especially with the checkpoint inhibitors, which have been used in oncology these days, drugs like Zumabs, acitazolizumab, and other drugs, they can cause hypophysitis and central hypothyroidism. So we should be vigilant. So yes. So Dr. Vivian, the question which comes into my mind is that, do we treat central hypothyroidism differently from hypothyroid?
Oh yeah, absolutely. So if you remember when I gave the talk, that little think about primary hypothyroidism, the first thing that moves is the TSH. So if you're talking about hypothyroidism, I would be expecting a TSH to be high. So many people, when they start treating, and they treat to normality, and if they see a TSH which is low, in this case, which is central, it's a pituitary tumor, something like hypophysitis, so you have no command hormones, TSH is going to be low. And people would then think, oh, have I over-treated this patient? So that would be bad, because you haven't over-treated the patient, the TSH will never rise because it's no production by the pituitary or the hypothalamus. So what I would treat them is just to look at the PT4. and then I would treat to the upper limit, as in the upper half of the range. That would normally what I do in my practice. But be very mindful of the fact as well that not everybody's free T4 is the same. So you should also go by symptoms of whether this person has thyrotoxicosis.
Thank you.
Normally what I do.
Yeah. Yeah, well taken your point. I will keep you busy, Dr. Vivian. Yes, of course, we keep on giving thyroxine, but any role of T3 in management of hypothyroidism?
In general, hypothyroidism, right? Yeah, if you look from my talk, I would say for me personally, it will be a limited role because we are already having so many confusing data with regards to which is the level of TFH we're talking about. If we have frank hypothyroidism, T4 management, perfect, no problems. I find that T3 comes in only when the people have a TSH, which is already in the reference range. And then they have these subtle symptoms. And I find it very difficult then to immediately latch on to T3. So when I see this group of patients, number one, I have to make sure that these symptoms that they are talking about, are they really hypothyroid symptoms, especially if the TSH is normal. I do not use free T3 in general for a patient who has who's being treated for hypothyroidism, being mindful of the fact that the free T3 marker is not the most reliable. So I would make sure also there's an open mind, exclude other causes that can cause the symptoms. Most of my patients who are purporting to be hypothyroid symptoms actually have psychosomatic symptoms. Second one, it could be that basically it's obesity. It's because of the obesity that is causing that. So, and I've got lots of patients come actually being treated unnecessarily, whether it's T4 or T3, and have successfully removed them from the T3 and T4, lost weight, they felt better. So I would say that if you really, really want to give, be mindful of the symptoms, don't enable them. Discuss very clearly with the patient, like what I was alluding to in my talk. What are their concerns? Whether this can or cannot be alleviated. We want to avoid at all costs escalating doses because the patients keep complaining every 2 or 3 months after the placebo effect has worn off, and now you're pushing them into frank thyrotoxicosis. So if you want to give them, do give them at respectful of our physiological dosing, which actually should be a T3 to T4 ratio of 1:13 to 1:16. So if you're doing desiccated thyroid, or you're going to give 1:4, and many of the studies, they're actually supraphysiological doses that might actually cause transient thyrotoxicosis in between. So that becomes, a totally big ball game again. Very, very difficult.
Do you have T3 in your country?
I do have T3 in my country. Yes, about 25 micrograms.
Okay, Dr. Manas, I feel we don't have T3 yet available in India.
Yeah, I don't think any Indian pharmaceutical company is manufacturing, but of late, I guess Glenmark has offered, they have submitted for patenting. I mean, they have developed something, but it's in a very basic state. But we do have in the metro cities, we have to get them from there. And I only use it in thyroid storm sometimes, but I have not used it routinely in hypothyroid patients because the cup is a bit controversial. And I personally feel, Mother Lisa has kept at a very, very low T3 level in the human body, and T4 should be good enough, and then we have got good deiodinase, those cell proteins. So as of now, I don't recommend T3 for routine use because it's risky. If you leave it to the physicians to use it routinely, might lead to a lot of side effects.
Yeah, I think we must be careful using T4 and T3 treatment, especially in childbearing age women, because
Dr. Samir, interestingly, there are some manufacturers in North India, around Delhi, who are manufacturing T3 the weight loss medicine. You can find it in internet.
So I agree. We must be vigilant, as Dr. Vivian was suggesting us. Dr. Manas, thank you. I think we are rarely using it. Dr. Faria, do you have T3 in your area?
No. It's
okay.
Available.
And Dr. Thanthan?
No.
Okay.
Not available yet.
Okay, so we have to be friends with Dr. Vivian to procure it, I think. So Okay, fine. So yeah, most of our patients are taking thyroxine. That's what we do. Even in myxedema coma patient, we give them a loading dose through Ryle's tube, and then we put them on physiological doses. We just give a loading dose of around 500, 400 microgram on first day, and then the single dose depending upon the body weight. So Dr. Faria, what we have observed is that sometimes the patients are taking thyroxine and still, since we monitor primary hypothyroid patients with TSH once they are on thyroxine, but we find the persistent elevations in TSH in spite of full replacement doses of thyroxine being given. So how do you go about in these cases, Dr. Faria?
Thank you for the question. And actually, few factors or few circumstances must be considered while the patient is taking the full replacement dose but not achieving the target TSH. The first thing, there may be some gut absorption problem or increased in metabolism or some diseases that increases the metabolism. There may be presence of some drugs like iron, calcium, he or she is taking along with the thyroxine. So in that case, it is not getting effective in the highest dose also. In patients who are getting few drugs like phenytoin or carbamazepine, in that cases also there is increased clearance of the thyroxine. And poor compliance, of course, a factor should be considered because we must ask the patient if he or she is taking the thyroxine at least 1 hour before the meal. Sometimes in our cases, sometimes it happens the patient is taking in the evening or in the after meal. In that cases, the effectivity of the thyroxine replacement is not so much. After excluding all these points, we must consider another very rare situation, the refractory hypothyroidism. This is another issue, must be addressed, though very rare, but refractory hypothyroidism is a condition when there is no problem with the gut absorption or metabolism or any clearance or presence of any drugs, but the requiring very high dose of thyroxine to maintain euthyroidism. That case, it should be diagnosed properly, and in some patients, and even 1 or 2 of my patients getting high dose of thyroxine but not achieving the target TSH. So refractory hypothyroidism should be properly treated, and in that cases, in few cases, T3 replacement is indicated, but it should be used very cautiously. And on the other hand, in some cases where available, the intramuscular use or parectal use of thyroxine may be sometimes helpful in these refractory hypothyroidism cases. But that is very much rare condition. Before that, we must exclude the other causes.
Yeah, I fully agree with you. Compliance, malabsorption, some rare conditions have to be ruled out why the patients are not responding to thyroxine and there is a persistent elevation in TSH. I think each case has to be dealt individually, and I think specialists must be brought into the picture once the patients are on thyroxine. Replacement doses according to body weight are good, but still the TSH is high. So there can be so many causes, as Dr. Faria was telling us. Any dietary precautions or interventions in hypothyroidism? Dr. Thanthan, would you like to take this?
Dietary precautions. Actually, there are the main elements which is important for thyroid functions are the iodine, selenium, nitrogens, and soy protein. There are 3 main aspects regarding the food and nutrition for hypothyroidism. One is the foods that contain certain nutrients such as iodine, selenium, and zinc, which can help maintain the thyroid function. Second point is the food may negatively affect the thyroid function, worsen symptoms of hypothyroidism.
Okay.
Some food supplement can interfere with the absorption of thyroxine. So iodine, regarding the iodine-rich food are actually the many sources, seafood and seaweeds and so on. But the commonest source of the iodine is actually the iodized salt in our country and so also in the other parts of the world who are under the WHO salt iodization program. So iodine, as you all know, is an important raw material for the thyroid hormone synthesis. And because body cannot make iodine, we have to take the iodine from the diet. However, it's crucial to avoid thus consuming too much iodine, because excess iodine can actually cause worsening in hypothyroid, and it depends on the status of thyroid sufficiency or deficiency. So we have to be cautious, and I think we are advising for the iodine for the patients with hypothyroidism. We must be careful. Food, another one is selenium, which is a micronutrient which plays an important role in the thyroid hormone synthesis, and also as an antioxidant, it's protect the damage of thyroid by the reactive ROS, reactive oxidation substance. And another point is that zinc. Zinc also is useful for supplement together with the selenium. Regarding the food to avoid, which contain the nitrogens and also the soy, which also have some inhibitory effect on the thyroid function. But in the real practice, I think these nitrogens actually can be damaged after cooking, and then the iodine is not a main problem in our country. So the suggestion to avoid these nitrogens, which are actually the vegetable, which is very beneficial for overall health. So we not usually ask them to avoid all of these nitrogens food, but we ask them to take in moderation. And then also the soy also is said to be a inhibitory effect on thyroid peroxidase, which is important enzyme for the thyroid synthesis. So the soy also is one of the inhibitory factor for the hypothyroidism. But in real practice, we usually ask them to take in moderation, and because in some research, they say that the soy is safe if the iodine is sufficient. So regarding the dietary advice regarding thyroxine therapy, it is important to take thyroid medication in an empty stomach. There's important factors everybody know. And there's some substance which can prevent interfere with the thyroxine absorptions, like antacid, milk, calcium supplement, iron supplement should also be in a white, and to have to be quite some 4 hours apart from the thyroxine treatment. So in conclusion, some nutrients and foods are beneficial and some need to be avoided, but in real practice, we usually emphasis more on the thyroxine therapy rather than food to be avoided or taken. I like to invite opinion from the other, from chair and other panels. So thank you.
Thank you, ma'am, for your elaborate comments. I think diet and hypothyroid, it's my Google patients who tell me more. Dr. Manas?
Yeah, right. We have to be very cautious.
Yeah, people have.
Same here in Bangladesh.
Yeah.
Each and every thyroid patient ask about what about the diet habit,
Yes.
what change they have to do, any restrictions or like this.
Patients will go to Dr. Manas. They have paid around 1,000 rupees consultation. He just tells them to continue same treatment. They are still angry with him. You have not told anything about diet. Dr. Manas, and
Yes.
patients tell us they are consuming senda namak. So a lot of myths, I think, are associated with diet and hypothyroidism. Dr. Thanthan has beautifully elaborated, but this is happening to me. Patients are consuming rock salt, low iodine salt, and they said, I will not consume cabbage and so many things. I think a lot of myths which are being associated. Another area where patients are telling me is that I need to take vitamins. Do I need to take, if we have an intelligent Google patient, he will tell me, why have not you prescribed selenium also to me? Dr. Manas, how to tackle these issues? Any role of vitamins and selenium?
Yeah, selenium has been associated, hypothesized to be associated with hypothyroidism for a long time, but till now we don't have any concrete evidence to suggest that selenium deficiency can lead to hypothyroidism. Yes, selenium is an important component of all selenoproteins, and iodines are the top level selenoproteins, but it is a trace element, and you need only a few maybe nanogram or microgram of selenium in your body to maintain that deiodinase activity, and it is preferentially preserved even in the face of selenium deficiency or malabsorption from the gut. So I don't think supplementing selenium routinely in a common garden variety of hypothyroidism would help. And as of now, I think we should not suggest that this is useful, because otherwise then you open a floodgate of off prescription medications containing selenium and other trace elements. Another issue is vitamins. In fact, I would rather say one vitamin which is so commonly used, biotin, and I've also already seen a question from my friend Dr. Angie Sinha. Biotin is a component of various multivitamins, and it can actually lead to a falsely raised T4, T3 level, and can also lead to low TSH level, which might sometimes create confusion for your patients and for yourself also. So one has to stop it before going for a thyroid function test. And lastly, vitamin D, like everybody is associating vitamin D with their own disease in their own field. I strongly disagree at this point of time. We don't have any evidence to suggest that it can actually lead to an alteration in the HP axis. But yes, vitamin D deficiency is fairly common, and hypothyroidism is also fairly common. So there can be some association, but the causality relationship is yet to be proven. So I don't think we should be prescribing vitamin D just to prevent hypothyroidism as of now.
Thank you, sir. I think there has been some studies which have shown some decrease in TPO levels, or maybe improving some ultrasound thyroid parameters, or decreasing some incidence of postpartum thyroiditis.
From Indian study. But then we need larger studies. We need good meta-analysis for that.
Okay. So we have some interesting panelists audience, and I think we have very good discussions on most of the aspects. We can have still many questions going on, but I think we have discussed most of the relevant questions related to hypothyroidism. And we have some wonderful audience. I would like to thank all of them, like Dr. Amol Patil, Dr. Tanya, Dr. Saifuddin, Dr. Surender Gupta, Dr. Nikita, Dr. Pankaj Patwari, and Dr. Noni Singhvoya, who have joined from throughout India, maybe outside India also, for this interesting webinar. And they have a lot of questions. Maybe it will take us more than an hour to discuss, but I think most of the questions have been answered by our esteemed panelists. One of the questions which is interesting by Dr. Noni is that how do biotin interferes with thyroid functions? Dr. Manas?
We mentioned it just now. Biotin can lead to falsely raised T4, T3 level and a low THS level. It would look like a mild hyperthyroidism. So one has to take the history. If you're not suspecting anything of that sort in your patient, but you're getting such a result, rather than blaming the lab, you can rather ask the patient what you're taking in recent few days. Are you taking biotin containing vitamin? And that can be stopped and can be repeated.
Yeah, I think, yes, that is one of the commonly used vitamins by dermatologists, and you can have this sort of picture. One other question was by Dr. Pankaj. If you have a malabsorption, then how do you treat hypothyroidism? I think you just have to correct the malabsorption underlying state. If the patient is having celiac disease, once you put these patients on gluten-free diet, I think you go well with thyroxine, and sometimes you have to decrease the dose of thyroxine also. And we had some students also, like senior resident, one of the senior residents from Bangalore, I think, Dr. Nikita, she has put up a question: how do you, the patient is on thyroxine and TSH is still high, can it be thyroid hormone resistance? I think that's altogether a different picture, where you have a T3, T4 on higher side, and also TSH, which can be in the normal range or maybe on the higher side also. But I think a different topic to discuss about. So I think it's time for us. Over to organizers. Thank you, all the panelists.
Thanks, Dr. Samir. I think it was really a nice discussion we had, and we discussed on lots of topics, and the panel discussion was really nice. So I will now hand over to Dr. Sarita Bajaj, ma'am. She would like to say thanks to everyone, and then we can close. Yeah, I think ma'am has some connectivity issue. Yeah, so yeah, ma'am is there. Yeah, ma'am, you have to unmute.
Yeah, I think I'm unmuted. Suresh, would you like to say a couple of words? Because he joined in late. Are you there?
Ma'am, I think he's not there, ma'am, at the moment.
Okay. Thank you, Pramila. Thank you. And of course, I think I cannot thank Vivian enough, because it must be close to midnight in Singapore. And knowing that we started the session according to Singapore time as 10:30 p.m., she very kindly agreed to stay on for the panel discussion. So thank you, Vim. I really enjoyed the case presentations, which are of great practical value. Thank you, Vivian. Thank you, Samir. Your inputs have been extremely valuable.
Thank you, ma'am.
Apart from conducting the panel discussion in such a nice manner, for every comment, for every question answered, you've had, like a special input, which has added a great value. Manish, it's lovely seeing you again. And I think you're an asset for any meeting. Dr. Thantanai, it's been a pleasure having you with us all the way from Myanmar. Thank you. And thank you so much. I think you're joining most of our programs and encouraging a lot of audience participation as well. Faria, thank you. We've enjoyed your comments, your discussion, your participation. Thank you so much, Faria. And I'm being very particular about the time. She specially messaged to ask me, what time is it in India, so that we're sure that she's bang on time when she joins in. Pramila, thank you very much. Arun, Minnie, Dr. Rao, they're an integral part of the executive committee of the ITS. And Ashmita, can we have the flyer for the next meeting, please, so that the audience who have logged in knows exactly what we are doing. Thank you, Vivian. You've been just wonderful. Your talk, I cannot thank you enough. The cases have been brilliant, absolutely brilliant. And you're just staying around with us for the panel discussion. Thank you so much. So what do we have for the next week? We have 2 case discussions, one followed by a quiz. And we have, I think, if I reveal the cases now, then I've just let the cat out of the bag. And I don't want to do that. So there are 2 brilliant case presentations from St. John's, Bengaluru. In between, we have a thyroid quiz as well. And I think a lot of participants enjoy the quiz because they get a prize for that as well. Thank you. Thank you very much. Over to you, Pramila.
Yeah, thanks everyone. I think ma'am has nicely concluded the whole session, and she has nicely told about what all we discussed today. So I think it was nice. We had nice discussion on hypothyroidism. This is something which we normally don't discuss so much in our other CME meetings. And this is a very relevant topic which we need to always discuss. And there are so many myths surrounding the diet and all those things which we nicely discussed. So I think with this we end. It's already very late for everyone. So thanks everyone and good night.
Good night.
Good night.
Good night.
Good night. Bye.
Thank you.